So today I'm going to discuss a case of vaginal hysterectomy that was done after previous four patient had previous four cesarean sections. We'll discuss that case and a bit of literature review of the cases in which vaginal hysterectomy is done and they have a previous cesarean section. So the patient was 40 years of age, para 4, and she had previous four cesarean sections. The presenting complaint was something coming out of vagina for 3 years. Risk factors were obesity, a BMI of 38, and history of herniorrhaphy for paraumbilical hernia, 5 years back. On examination, there was a 3 inches long horizontal paraumbilical scar of previous herniorrhaphy, a fennel steel scar of previous cesarean section, and a 12-week size well-supported uterus with an elongated cervix hanging 4 centimeters outside the vagina. This is POPU stage 3. So the management dilemmas for vaginal hysterectomy and against vaginal hysterectomy. For vaginal hysterectomy, there was a paraumbilical scar of previous herniorrhaphy. There was a fennel steel scar of previous cesarean sections. The cervix was elongated and 4 centimeters outside the vagina, and the BMI of the patient was 38. And the factors that were against vaginal hysterectomy was there was a 12-week size well-supported uterus and previous 4 cesarean sections. So the risk factors were taken into consideration. Abdominal hysterectomy versus vaginal hysterectomy was discussed with the patient. Informed consent was taken about the risks of complications, and a plan of vaginal hysterectomy was made. The patient consented for a conversion into abdominal procedure if the need arises. Gut preparation was done preoperatively and blood was arranged. So the procedure was started, and you can see in the diagram, in the picture, the cervical elongation. So it was very difficult to open the anterior and posterior pouches, and we were not able to open them initially. Gradually, after clamping, in the end, we opened the pouches, and it was a well-supported uterus with cervical elongation. And here you can see the clamping of the cardinal ligaments and the uterine pedicle. And again, you can see how long the cervix is, and it is very difficult. It was difficult to apply the clamps. And this is the final ligament, tubovarian. And you can see again that the length of the cervix is very long, and it made this hysterectomy quite difficult. And another thing was that the uterus was 12-week size. There were previous 4 cesareans. So it was done very carefully. It took time, about 2 hours. And this is the final suspension of the vaginal cuff by suturing it to the uterosacral cardinal ligament. So the post-operative care, the surgery took around 2 hours. Post-operatively, urine was clear. There was minimal bleeding. No blood transfusion was needed. Vaginal packing and Foley's catheter was retained for 24 hours. Patient was discharged on the second post-op day without any complication. And patient came up for follow-up visit after 1 week of discharge. Patient was healthy without any active complaint. So what are the concerns in patients which have to undergo a vaginal hysterectomy but have previous surgeries? Is there an increased risk of bladder injury, increased risk of injury to the rectum, increased blood loss, or delayed recovery? So I just did a bit of literature review to see the studies that were done on such cases. So this was a study which was a history of cesareans is a risk factor in vaginal hysterectomy. This was over a it was done over a period of 8 years, and hysterectomy for benign lesions was studied. It was a comparison of 2 subgroups, one which had a history of cesarean section and another which did not have any cesarean delivery before. In patients with history of cesareans, 13 perioperative complications out of 71 hysterectomies, that was 18.3%. You can see in the graph that in the patients with history of cesarean, there was more than 18% complications, whereas in those where there was no history, 3.5% only complications. So this study showed that there was an increased risk of complications in patients who had previous cesarean deliveries. Another study was vaginal hysterectomy in women with history of previous cesarean deliveries. This study aimed to compare surgical outcomes with vaginal hysterectomy between women who had more than one cesarean delivery and those who had not had a cesarean delivery. It was a retrospective analysis. It was performed on 225 women undergoing vaginal hysterectomy. Women were separated into those who did have a history of previous cesarean deliveries and those who did not have. So the results was that the previous cesarean delivery did not affect the hemoglobin change, hospital stay, operative time, but the complication rate was again slightly higher. It was 11.3% in women with previous cesarean group versus 4.3 in the patients who did not have a previous cesarean section. Another study was perioperative outcomes of total vaginal hysterectomy in women with a prior cesarean delivery. This was done in a tertiary care academic institution. 742 women who underwent total vaginal hysterectomy over 5 years were included. And the results are shown in the graph. There was a slightly increased risk of cystotomy, ureteral injury, proctotomy, postoperative bleeding. There was no case of reoperation in the case of previous cesarean section, but the most significant finding was the increased risk of blood transfusion. That was about more than 5% in the cases where there was a previous cesarean delivery, and less than 1% in those where there was no previous cesarean delivery. So the results was that the prior cesarean did not increase the overall rates of the Cliven into grade 2-3 complications. The grade 2 complications are those that require pharmacological treatment with drugs other than antiemetics, antipyretics, analgesics, diuretics, electrolytes, and physiotherapy. And grade 3 complications are those that require surgical, endoscopic, or radiological intervention postoperatively. So these complications did not increase overall, but the risk of blood transfusion was greater in those who had a previous cesarean delivery. So there was another study of risk of bladder injury during vaginal hysterectomy in women with a previous cesarean section. It was analysis of selective studies from 1980 to 2003. 4 comparative studies were selected and analyzed. Risk of bladder injury was significantly increased in only one study. Analysis of cumulative data did not find a significant difference. And the conclusion was that the risk of bladder injury during vaginal hysterectomy does not seem to be increased in women with a previous cesarean section. And the rates of bladder injury were not statistically significant in patients undergoing vaginal hysterectomy after previous cesarean, and the rate was 1.86% versus 0.89%. And since our patient was obese, so I also included a study, does route of hysterectomy affect outcome in obese and non-obese women? A chart review of 293 hysterectomy procedures was performed. BMI, operative time, estimated blood loss, change in hematocrit, hospital stay, and complications were recorded. And the positive finding was that in the abdominal hysterectomy route, there was more blood loss in the obese group and even in the normal weight group as compared to the vaginal hysterectomy group. You can see that there was approximately 455 ml blood loss in the obese group that underwent an abdominal hysterectomy, and it was almost half, 263 ml, in the vaginal hysterectomy group. And similarly, the duration of hospital stay post-operatively in the obese group was 4.23 days approximately, and that underwent an abdominal hysterectomy, and it was only 2 days in those patients who underwent a vaginal hysterectomy. So for normal and obese women, vaginal hysterectomy offered the shortest hospital stay and surgery time, and the average blood loss was also reduced in the vaginal hysterectomy group. Another study was surgical outcomes between routes of hysterectomy in patients with a previous cesarean section. It was done to determine the difference in surgical complications for patients with a previous cesarean section undergoing abdominal, vaginal, or laparoscopic hysterectomy. It was a population-based retrospective cohort study carried out in province of Ontario, Canada. 10,300 patients with at least one cesarean section between July 1991 to February 17, 2018 were included. And interventions were a benign non-gravid hysterectomy between April 2002 to March 2018. It was a retrospective population-based study. The adjusted odds of any surgical complication from hysterectomy was significantly lower when performed by the vaginal approach than the laparoscopic approach, and vaginal approach had better outcomes than the abdominal approach. So the final result was that patients with vaginal hysterectomy experienced lower risk than either the abdominal or the laparoscopic approaches. So the conclusion, some certain studies are showing that the vaginal hysterectomy is having more complications, and some studies say that the complication rate is not statistically significant. So whether vaginal hysterectomy is an appropriate route of surgery in patients with previous cesarean deliveries remains a topic of debate. Vaginal hysterectomy may be more challenging because of decreased mobility of the uterus from the adhesions of cesarean deliveries. However, adequate surgical expertise to attempt vaginal hysterectomy remains the key. Informed consent should be taken, and the risk of complications must be discussed with the patients, and there should be flexibility in converting to an abdominal hysterectomy if any difficulty is encountered. Thank you.
Okay, good presentation, Sadaf. This is Nuvera. So I just have one question. When you were scrubbed during this surgery, what do you think was the most difficult part to do? Can you hear me? Am I audible to everyone?
G, I can
Yes,
hear
ma'am,
you.
you're audible.
Yes, Dr. Noera, we can hear you.
Okay, so did you hear my question or should I go again?
No, I didn't hear your question, please.
Okay, sorry. So I said, Sadaf, when you were scrubbed in this surgery, what was the most difficult part that you thought was the step of the surgery? Which part was the most difficult?
The most difficult was opening the peritoneum, the anterior and posterior pouches, because the uterus was very well supported and we couldn't open the pouches initially. So after successive clamps and then it was opened quite late. That was difficult to mobilize the uterus and open the pouches.
Okay, thank you.
Okay,
Mr.
Sadaf,
Madam,
this is
I have one question. I'm Sadia from Ahmedabad.
okay. You go ahead.
Yes, ma'am, I just wanted to ask that we are doing the, vaginal hysterectomies in the previous cesarean section. So how much, usually the patients who are giving birth through cesarean section really have the well-supported uteruses. So how many patients were, they are giving us the data of 298, patients. They were included who are statistically significant data they provided. So how many patients having the uterine prolapse requiring vaginal hysterectomy after cesarean sections? This is not coping in my mind.
These are the
Sadia, so acha,
yeah, नहीं डॉक्टर
go
मेरा
on,
you go ahead.
Roj.
नहीं कोई बात
Okay,
नहीं, go ahead.
so okay, Sadia. So basically, vaginal hysterectomy is a documented standard procedure, and according to literature and according to some experts as well, cesarean section is not an absolute contraindication for going ahead for vaginal hysterectomy. Now there are two things. One is that you have prolapse with previous cesarean sections, and the other, which we usually find, is basically cervical elongation and hypertrophy with cesarean section. So basically, the body of the uterus doesn't come down, but the cervix is elongated and hypertrophied, like you just saw probably in the case here as well, right? So, but then again, because it's a standard procedure, it's a least invasive procedure as compared to laparoscopy and abdominal hysterectomy. If you're trained as a urogynecologist, you can and you will be inshallah able to do all of these.
Thank you very much.
So
I would add something in it. I got your query in your mind, and they first of all you were surprised because of the numbers. So these are the centers who get referrals, and these are tertiary care hospital. Are the if you could see the data for us for a longer period of time, like for 10 years, for 5 years. Number one. Number two, we have done such cases in which a patient had previous scars. So these are the women who are multiparous. Some of the women were multiparous. They delivered vaginally too, and at the end, their last delivery was C-section. I have done one case of previous to scar too. That was the patient who delivered all the patients who took a trial of labor in the first delivery, and then she had prolapse, and after that subsequent C-sections too. So there are cases, and number of cases were spread out, like these were for numbers of, but I would not encourage or recommend if you attempt non-descent vaginal hysterectomy in a patient with previous scar. If prolapse is there, then one can always try, but with the experts. So my question was, before Sadia asked a question, Sadaf, I was about to ask a question from you. What were the factors which could help you in taking the decision? Like she had prolapse stage 3, that was the case. But how did you evaluate if if this patient is coming in your clinic? Sadaf, are you getting me? Or sun rahe ho,
Yes,
beta?
yes, I'm.
Okay, if she's coming in your clinic, say, and I have asked you to examine that patient. She is in lithotomy position, and if I ask you कि आप इसको examine करें and tell me what are the positive points or what are the examination finding which can help you to predict the success of your surgery vaginally, how would you go about that?
In this case, the patient had like 5 surgeries, like 4 cesarean sections and one
No,
paraumbilical hernia repair,
pertinent
and her BMI was
point.
38. So it was
Examine.
difficult to decide whether we have to go for
Yeah.
an abdominal route or a vaginal route. And since it was about 4 centimeters outside the vagina, the cervix was there, and so we thought over this, and then we
No, I
decided
have
that
asked you.
we
You're
should
standing
try
in
it.
front of
And but there was
stuff.
an option in mind that if we encounter any difficulty, we will convert it into an abdominal procedure,
No,
so that
I
basically
know.
the left side is
Excuse me, beta.
the grade of
But
prolapse, and
exactly.
the cervix was like 4 centimeters outside the vagina. So that was the point that made us go for the vaginal hysterectomy.
No, if I asked you, अच्छा, any one of the fellow can answer. Anam, are you getting me? आपको मेरे
Yes.
आवाज आ
Yes.
आप
Basically,
Madam, can we
yes.
only talk about the cervical elongation management? So,
hello.
No,
although the Manchester repair is
my question. Let me clear my question. I have asked my fellow to examine the patient and tell me what are the positive or good points in this examination which can predict success of my surgery. आप किन points पे उस patient को examine करेंगी? History तो हो गई है, सब कुछ हो गया, आपने abdominal भी कर लिया. मैं आपसे कह रही हूँ कि मुझे
Okay.
vaginal examination करके कोई 1 या 2 points बता दें जो मुझे encourage करे in taking the decision.
Okay. When we are standing.
Decision हमें ये हो गया है ना, हम यूए करेंगे, हम अटेम्प्ट करेंगे सर्जरी को बिकॉज पूरा यूथ प्रोलैप्स्ड है और ये सब कुछ.
Can I
कुछ
answer
और भी
that
हेल्प
question?
है?
Hello.
जी
Can I answer
जी
this
जी
question?
जी करें
Mobility
आंसर.
of the
Okay.
mobility
So when
of
we
the
are
vaginal
examining the
mucosa.
patient, basically we look for the vaginal spaces. Do we have an adequate space? We look for the size of the uterus, mobility of the uterus, and any coexistent uterine pathology. And then we decide whether the non-descent vaginal hysterectomy would be successful or not. And
नॉन
obviously,
डिसेंडिंग प्रोलैप्स है, ठीक है. ओके, अच्छा वो भी कोई पॉइंट कह रही थी डॉक्टर सादिया जी. डॉक्टर सादिया.
Yes, ma'am. I just wanted to add this point that during the examination, we wanted to we wanted to see for the mobility of the uterus, because after the peritoneum, this is the most difficult
नहीं
part
कोई
and very
edit
basic.
नहीं आपने एडिशनल.
नहीं मैम, यही चीज है.
ठीक है, और मोबिलिटी ऑफ द यूट्रस देखेंगे. मोबिलिटी ऑफ द म्यूकोसा, the vaginal mucosa at the site of previous scar. Okay, if the tissue are a little bit mobile with experience, you can gain this expertise that you can just predict that, okay, if the tissue are mobile, some extent that can be wrong too because this is non-specific, but that you can always gauge, of course, the mobility of the uterus and mobility of the mucosa. All right. Shalem. So very good presentation, Sadaf.
Thank you.
And Dr. Annam, you can share your slides now.
our slides are being shared. I hope you can see.
Yes, we can, Anna.
Yeah.
Okay.
Sorry, I didn't see.
Okay. So I'm presenting a journal club, and the title of the article is Sacrospinous Hysteropexy versus Prolapse Hysterectomy with Apical Fixation. This is basically a retrospective comparison over an 18-year period. So the background of the study is basically that the pelvic organ prolapse is a common health problem, and due to the world's increasing older population, its incidence is rising. And out of this symptomatic population, about 3 to 6%, they are associated with symptoms including bladder and bowel issues, as well as sexual dysfunction. So the treatment options, they range from the conservative options like pessary application to various surgical methods. And even in the surgical methods, we have options for uterine conservation versus removal of the uterus. And vaginal hysterectomy is still being the standard procedure in many countries, and it's practiced worldwide. So prolapse hysterectomy independently increases the risk.
I lost connection for a while. Can you just show the first slide, please?
Okay.
Sorry. Okay.
So the title is Sacrospinous Hysteropexy versus Prolapse Hysterectomy with Apical Fixation. This is a retrospective comparison over an 18-year period. The background of the study is that pelvic organ prolapse is a common health problem, and due to the world's increasing older population, its incidence is rising. And out of the symptomatic patients, about 3 to 6%, they are associated with symptoms including bladder and bowel issues, as well as sexual dysfunction. Now, the treatment options that we can offer to the patient vary from the conservative options to the surgical options. In conservative, we have pessary application, and in surgical, we can give the option of uterine conservation as versus vaginal hysterectomy or removal of the uterus. Vaginal hysterectomy is still being the standard procedure in many countries. Now, prolapse hysterectomy independently, various studies have shown that the prolapse hysterectomy independently increases the risk for a subsequent prolapse or recurrence even in nulliparous women. Uterosacral ligament suspension and sacrospinous ligament fixation are often recommended at the time of vaginal hysterectomy in order to prevent the recurrence of the prolapse. Now, as women have expressed more and more desire to keep the uterus, procedures that preserve the uterus, such as vaginal sacrospinous hysteropexy, are becoming more popular as primary surgical treatment option for pelvic organ prolapse. Sacrospinous hysteropexy is a uterine preserving procedure. It has gained popularity after the publication of SAFE-U trial, where the sacrospinous fixation versus vaginal hysterectomy was compared in your treatment of uterine prolapses with POPQ stage greater than 2 trial, and it was conducted by the Dutch research group. So the objective of this study was to evaluate peri and post-operative outcome parameters of uterine preserving sacrospinous hysteropexy as an alternative treatment option to vaginal prolapse hysterectomy with apical fixation. So this is a retrospective cohort study. The demographics and clinical information, including confirmation of the pelvic organ prolapse, as well as the assessment of pelvic floor muscles in accordance to the Oxford scale, and operative records were obtained from the included patient's electronic hospital chart. All patient records were anonymized and de-identified prior to analysis, and post-operative complications were assessed through the standardized classification of surgical complications according to Cleveland-Dindo. Both the post-operative complications, including the inpatient stay, as well as the complications that were considered during the follow-up period, were assessed through this standardized classification. This is basically the Cleveland-Dindo classification. There are basically 5 grades, 1, 2, 3 is further divided into A and B, 4 again divided into A and B, and 5. A1 is basically any deviation from the normal post-operative course without the need for pharmacological treatment or surgical, endoscopic, and radiological interventions. And acceptable therapeutic regimes are drugs such as antiemetics, antipyretics, analgesics, diuretics, and physiotherapy. This also includes wound infections opened at the bedside. Grade 2 is basically requiring pharmacological treatment with drugs other than that allowed for grade 1 complications, like other than antiemetics or analgesics. Blood transfusions, antibiotics, and total parenteral nutrition are also included. In 3, we consider requiring surgical, endoscopic, or radiological interventions. A is basically in the regional anesthesia, and B is under the general anesthesia. 4 is including the life-threatening complications requiring intensive care unit management. A is basically a single organ dysfunction, B, multi-organ dysfunction, and 5th is patient demise. So this study was conducted in Department of General Gynecology and Gynecological Oncology and University of Vienna, Austria. Patients were assessed for eligibility according to the inclusion and exclusion criteria. So the inclusion criteria were patients who were having symptomatic pelvic organ prolapse that were coming to the tertiary hospital from 2003 to 2021. And they underwent either the primary sacrospinous hysteropexy. Patients undergoing sacrospinous hysteropexy were included in the study group, where the patients undergoing vaginal hysterectomy with apical fixation were included in the control group. Exclusion criteria was basically the emergency cases, treatment for non-urogynecological issues, any malignant results, or history of previous pelvic floor surgeries. Basically, a total of 1610 patients were assessed for eligibility. 1418 patients were excluded, either for not meeting the inclusion criteria or because of an incomplete data set. So the final sample size that were included was 192 patients, out of which 96 were in the study group and 96 were in the control group. So this is basically the flow of patients through the study, showing in initial eligibility assessment for 1610 patients, then 1418 were excluded. We were left with 192, and they were further grouped into two groups undergoing the vaginal sacrospinal hysteropexy or hysterectomy, vaginal hysterectomy. So all patients were operated by the vaginal route, and all procedures were performed by a surgical core team consisting of 3 consultants for the urogynecology and reconstructive pelvic floor surgery division, and a uniform technique was used. So the primary outcome parameters that were considered in this study were operating time, that was basically defined as starting and ending with the patient's anesthesia in the operating theater, intraoperative blood loss that was documented by the surgeons immediately post-intervention, intraoperative complications that were defined as any deviance from the standardized procedure documented by the surgeon, and intraoperative conversion to other surgical management options. Post-operative complications that were assessed were basically as classified by the Clavian-Dindo classification, as well as the post-operative urogynecological complications that were assessed were de novo incontinence or voiding disorders, pathological residual urine, vaginal infections, infection of the wound, profuse bleeding that required blood transfusions, and pain. So statistical analysis was performed by our core team 2022. Numerical data is described by medians and interquartile ranges. The potential difference in such variables were examined with the Wilson rank sum test. This is basically a comparing a test which is used for comparing the independent samples, and this is a non-parametric test. And categorical data are described by absolute frequencies, that is the qualitative data. For group comparisons concerning variables with 2 categories, Bernard test was used. Bernard test is basically also used for comparison of categorical data, and where we have 2 into 2 contingency tables, independent variables are included. In case of 3 or more, Pearson-Chi test was used, and p-values less than 0.05 were considered statistically significant. Now, 192 patients were included, 96 patients in each of the study and the control group. And the results of the study were that the patient characteristics, there was no statistically significant difference were found between the 2 groups. That the parameters were the baseline characteristics between the study and the control groups that were considered were age, BMI, menopausal stage, parity, mode of delivery, the preoperative POPQ stage between the 2 groups, and the preoperative health issues such as cardiovascular disease, renal disease, diabetes, or polymedication. So this is a table representation of the results of the patient's baseline characteristics of the 2 groups. We can see the age, the BMI, the POPQ, the cardiovascular issues, the diabetes. The HE is basically hysterectomy group, and the sacrospinal hysteropexy. We can see that none of the p-values is significant. For the age, it's 0.8, it's not significant. The BMI is 0.1, again, not significant. Similarly, the POPQ stage, the cardiovascular issues, the preoperative diabetes, none of them is having a p-value less than 0.05, so no characteristic was statistically significant. Again, the renal insufficiency, the polymedications, the menopausal stage, the preoperative parity, we can see that the p-value is greater than 0.05, it's 0.5, 0.4, 0.9, 0.6, so no statistically significant difference was found. Again, the sacrospinous hysteropexy groups, the statistically significant difference was the shorter mean surgery time with the sacrospinous hysteropexy group, with 65 versus 95 minutes in the vaginal hysterectomy group. So this was statistically significant. The p-values were less than 0.001. Also, there was a significantly fewer hospitalization days with 2.94 versus 4.87 days. Again, the p-value is less than 0.001, so it's statistically significant. And lesser intraoperative blood loss with 120 ml versus 186. Again, the p-value is 0.03. So these 3 parameters were there was statistically significant difference between the sacrospinous hysteropexy versus vaginal hysterectomy. So this is the graphical representation. We can see hospitalization in days chart. The first one is having sacrospinous hysteropexy, the other, vaginal hysterectomy, and the other one is sacrospinous hysteropexy. The pink ones, they are basically showing the inpatient stay of 5 to 7 days. We can see that is more in the vaginal hysterectomy compared to the sacrospinal hysterectomy. As I've already said, that the hospital stay was shorter in the patients who underwent sacrospinal hysterectomy, and this was statistically significant. Similarly, intraoperative blood loss, again, vaginal hysterectomy, sacrospinal hysterectomy, we can see the purple one is greater than 200 ml. It's more in the vaginal hysterectomy group. So again, this was statistically significant. This is a table representation of the same findings, the surgery time, the post-operative hospitalization, the blood loss between the two groups. And we can see in all that the p-value is, the surgery time is 0.000, hospitalization is again, p-value is less than 0.05, and the blood loss is 0.03. So all of these three values, there is a difference, statistically significant difference between the two study groups. Okay, intraoperative, there was no intraoperative complications were reported. No intraoperative conversion to another surgical method was documented. Post-operative complications, as already mentioned, were assessed according to the Cliven-Dendo classification. 3 patients experienced a grade 3B complication as characterized by the Cliven-Dendo classification, but no statistically significant difference between the groups was found. Study groups one of the patients within the study group had an episode of post-operative bleeding, and the 2 patients in the control group, one had complication of a zygovaginal fistula and one with an apex infection, but still the results were not statistically significant. Also, regarding the urogynecological post-operative complications, again, no statistically significant was documented. There was no difference in de novo incontinence, avoiding disorders, residual urine, urinary tract infections, vaginal infections, infection of the wound, bleeding requiring blood transfusions, and pain. Again, the post-operative complications, the patients with vaginal hysterectomy and sacrospinal hysterectomy, we can see that not much difference can be seen in the graph. The same information is depicted in the table. We can see the post-operative complication, UTIs, blood transfusion, bleeding, pains, and we all can see that the p-values are more than 0.05, means they are not significant. Again, the residual urine, the bowel issues, the wound infection, the fistula, they all are not statistically significant. So discussion, in the start of the journal club, I mentioned the SafeU trial. Basically, they involved 104 patients in each group, and they also compared the patients undergoing sacrospinal hysterectomy with vaginal hysterectomy, and the operative time consisted of 59 minutes in the sacrospinal hysterectomy versus 72 minutes in the control group, that is patient undergoing vaginal hysterectomy. And this difference of time was statistically significant. There was a shorter operating time in the sacrospinal hysterectomy group, and that is in line with this journal club, manuscript findings. No difference regarding intraoperative blood loss could be detected between the two groups. So our findings show a statistically significant diminished intraoperative blood loss in the sacrospinal hysterectomy group, 120 ml versus 186. Another randomized control trial that was published in 2010 by Dietz, they analyzed 66 patients where 33 cases underwent sacrospinal hysterectomy and 31 women received a prolapse hysterectomy with or without apical fixation. And again, there was significant reduced length of time to return to work in the sacrospinal hysterectomy group, significantly shorter hospitalization in the sacrospinal hysterectomy group, no post-operative complications. These post-operative outcomes as well as hospitalization rates align with the findings of this under the topic, the article that we are discussing. So the strengths of the study is basically that the large population of 96 sacrospinal hysterectomy patients that were well matched by age and BMI with patients receiving a primary vaginal hysterectomy with apical suspension. Also, there was no significant difference in the baseline characteristics of the groups. And the pre-operative clinical examinations as well as surgical procedures were all performed by a small group of experienced urogynecological specialists. The limitations was basically this was a retrospective cohort study, so it limits in determining a cause and effect relationship. There was no information on post-operative anatomical outcome available, and selection bias can be there, nor can a consistency in a pre-operative assessment be guaranteed. So the conclusion of this study was that uterus preserving surgical alternative shows several benefits. in terms of shorter operating time, reduced hospital stay, diminished intraoperative blood loss. However, long-term follow-up data are still very much needed. Thank you. Hello?
Hello. So thank you very much, Anam. It was a very, very well illustrated and very, very good, well analyzed journal presentation. The main uterine preserving surgeries which are performed in our unit are Manchester repair, where cervical elongation is there, and in those patients where cervical elongation is not an issue, sacrohysteropexy. We are not very routinely performing the sacrospinous uterine suspension. So I just wanted to inquire your experience, Novera and Aruj. Are you performing it? I mean, how are you doing it? You know, in this particular procedure, what is your experience with this?
So Dr. Nazli, we are routinely doing it now. We have been trained as a part of the fellowship as well, but we're more inclined towards it now because now the patients are also coming up and saying that we want to preserve our uterus, one. Secondly, we're more comfortable doing them. We're not using the industry-driven depends as the dollar has gone up, especially slim. But I think our duration of surgery has also reduced when we attempt a unilateral sacrospinous fixation procedures. So we are routinely doing them now.
So,
And our experience is quite good. The only thing that I wanted to ask as a question to the fellow is that we were basically we're attempting sacrospinous fixation, especially unilateral in old age groups, and we do consider their sexual activity as like one of the other considerations because especially with unilateral sacrospinous fixations, the
yes,
vaginal axis tends to divert to that side as well.
That was my second question here. Okay. So you can ask, you can proceed with your fellow. I mean, she can answer it, but that was my second concern,
No, exactly. So this is what I want to comment upon. Thank you for asking that question. So I think our question was sort of there was one question that I would like to ask the fellows, all of you, you mentioned the SAFE-U trial, right? And all of you have read the article as well. How was the SAFE-U trial different from this study?
Well, in that, apical suspension was not used with vaginal hysterectomy.
And were there some other
The sample size
analytical differences as well? Any other one? Any other? Sadia and Sada?
The sample size was 104.
That's okay. You can have different sample sizes for different studies. That's fine. But what was one major difference between that SAFE-U trial and this study? That was published about 10 years ago, right? 11, 12. That was 2010, right? So
it is a retrospective cohort. Ours one is a retrospective cohort study. Other that was a randomized control trial.
Yes, so basically that was a non-inferiority trial. If you've gone through even the abstract of the SAFE-U trial, this is for all the fellows, that it was a non-inferiority trial, right, as compared to this retrospective study. So what do you know what is a non-inferiority trial? Anyone?
I don't know.
I just want to clarify it here because it's okay if you don't know, but it's a good habit whenever you go through research topics and you want to know the applicability of your own practice, right, of that research. So evidence-based practice may non-inferiority trials, superiority trials, these are important, right, when you counsel the patient, when you want to perform a certain surgery as in comparison to the other surgery that is being routinely performed. So what will basically encourage you to do it, right? A lot of questions like that. So non-inferiority trial is a trial that is done for a new procedure, and you are not supposed to basically see if it is superior to the current treatment, sure that it is not inferior to the current treatment. For example, vaginal hysterectomy with McCall's culdiplasty, right? This is a standard procedure. And then when you're sacrospinous ligament fixation, and if you prove that it is non-inferior, it means that it's not worse than the current treatment. It's okay that you perform either one of them, right? So that is not inferiority. And superiority is when you try and prove that sacrospinous fixation is far more better than the vaginal hysterectomy. Okay, so that is when you tend to change your practice. That is when you tend to give the options of two procedures if they're comparable to each other, right? So please focus on these terms as well when you want to change your practice, right?
Okay.
Okay, thank you.
Dr. Novera, so Anam, I have a question.
जी
जी मुझे आपके दो क्वेश्चंस हैं. एक तो ये मुझे बताएं कि in the last I asked you, is this study or applicable to your population? Is this reproducible?
yes
We have to conclude a journal like this.
yes
Okay, so you can treatment to your patients too, and you have done it. Secondly, if you go back to your slide of blood transfusion, there were multiple tests to analyze the results. Multiple blood transfusion slide. Okay. So the purpose of journal club here is not to, yes, of course, we had a very good discussion on clinical practices too, but the purpose of journal club, presenting journal club, is to just enhance your capability of conducting research and to increase your interest and gain knowledge as much as possible. Like Dr. Navera described very much detail about the SafeU trial, and we got there were 2 or 3 learning points in that. So I want you know the blood transfusion slide. आगे जाएं ये पीछे. Yeah. So when you were preparing for this, इससे भी पीछे एक और slide थी.
these are the baseline characteristics.
Yeah. पीछे जाएं.
Hospitalization, there's blood loss. ये
So इसमें आप लोगों ने अगर ये पढ़ा है तो थोड़ा सा इसको डिस्कस कर ले तो बेटर होगा, अगर आपको इंटरेस्ट है तो.
जी
So ये टेस्ट क्यों लगाए गए थे और क्या था, हम क्या करते हैं इससे?
इस पे पियर्सन का ही टेस्ट लगा है ना ब्लड लॉस पे.
All right.
So basically, this is for categorical data. As we can see, the blood loss is qualitative data, categorical data, and basically, when it is applied, when we want to find out the associations between the two variables. That's.
So what about Wilcoxon rank sum test?
It is basically used for non-parametric. It is a non-parametric test, basically used when the data is not normally distributed, and it compares dependent samples.
And when we are talking about post-operative hospitalization days and blood loss in ml, it is not categorical data; it is numerical, isn't it?
Yeah, blood.
Yes, Madam, Dr. Nasli is very much right. When you are measuring something or you are counting something, so basically it is a numerical data rather categorical.
GNM.
Well, I believe that if we categorize blood loss into mild, moderate, severe, then it comes under the category of categorical qualitative data.
Yes, you are right, but it is in mLs, it is not in mild.
I think they've labeled the categories as like, less than 1 day, 2 to 4 days, 5 to 7, and then 8. I think that is how it can become. They've made these categories.
No, we are talking about the blood loss one. Because they have
so less than 100, 100 to 200, and then 200, I think.
Maybe because of that. So have they explained that in the study?
No.
So you might count it as a weakness. It was not explained.
Okay.
Anna?
So
go back to the previous chart. एक और भी है ना आपका ऐसा chart? So these bar graphs are very clear. They're easy to understand. Okay, so go one by one. This one. All right, so they're talking about the post-op complications. So can you explain this table to me, Anam?
Okay, so the post-operative complications that were considered were UTIs, blood transfusion, post-operative bleeding, and post-operative pain. They were compared in the groups of vaginal hysterectomy and sacrospinal hysteropexy. The p-value was calculated. So the patients out of patient who had post-operative complications, there were no complication in 156 patients. There were complications in 36 patients. Out of the 36, 22 fall into the category of sacral.
So my question remain the same. Why did they use this Bernard and conditional test for this particular table? How is it relatable?
Basically, they have compared categorical data again, and Bernard test is mostly used when we want to have 2x2 tables, contingency tables comparing the independent variables.
Okay. So how this table is 2x2?
We have compared for example, it's the UTI in the sacrospinous hysteropexy group and UTI in the vaginal hysterectomy group. So this makes in 2x2 table.
Sorry, I was disconnected for a little bit of time.
Okay, I said that if we are comparing UTI in the two groups, so the 2x2 table is created by considering the UTI in the sacrospinal hysteropexy group and the UTI in the vaginal hysterectomy group. So we get a 2x2 table, and that is where we use the Bernard's test because it's including the categorical data.
All right.
And
so do you have any other tests in this study?
We have Bernard test, we have Pearson chi-square test, we have Wilson rank test.
All right. So far this table looks fine, है ना?
Ji.
All right. Is there any other question? So, thank you very much, Anam. If all fellows are here till now, so we can just discuss for the next presentation.
Yes.
All right. Thank you very much, Anam. I think you had a thorough presentation and very good knowledge on the test, because I categorically told you I'm going to ask these questions from you. It's very important for the next journal club to be presented like that. So हम अभी रोटा निकाल के डिस्कस कर लेते हैं. Dr. Sadia, are you going to be there for the next presentation?
Yes, ma'am. Why not? Thank you very much for your cooperation from last 2 weeks. Thank you so much, ma'am. Hello, madam. Can you hear me?
I'm just going back to the chemic rota. Yes, कोई बात नहीं बेटा. I'm just going back to the chemic rota. ठीक है? So again, there is a topic of urinary incontinence and the evaluation. So we are just looking forward for a journal representation. To Dr. Sadia, you can take it because
sure, ma'am.
Yeah. और
Yes,
थोड़ा सा एक्सप्लेनेशन बता दूं कि प्रेफरेबली वो लेटेस्ट आर्टिकल होना चाहिए और किसी रिनाउंड जर्नल में. और जो है आपका जैसे अनम ने प्रेजेंट किया रिट्रोस्पेक्टिव था, क्योंकि मैंने इसको टिपिकली ये कहा था कि कंजर्वेशन ऑफ यूट्रस करें, मगर प्रोस्पेक्टिव स्टडी और रेंडमाइज्ड कंट्रोल ट्रायल हो तो बेटर होता है. क्वालिटेटिव चाहिए, इसी तरह की क्वालिटी अच्छी हो. ठीक है. और द अदर वन इज द केस, बिकॉज हम इजीली कर पाते हैं. डॉक्टर मेरा ख्याल है कि हम 2 प्रेजेंटेशंस 1 घंटे में, तो अदर हम ये कर लेते हैं कि एक केस प्रेजेंटेशन मैंने ये रोटा में। सो अनम और सादिया जो भी प्रेजेंट करना चाहे, यूरिनरी इंकॉन्टिनेंस है, प्रेफरेबली पेशेंट शुड हैव यूरोडायनामिक स्टडी अगर हो, और आप लोग इनकॉन्टिनेंस का केस प्रेजेंट करें तो फर्स्ट लेवल का होना चाहिए, लाइक कैन बी अ कॉम्प्लिकेटेड mixed urinary incontinence that require urodynamic study, or a different sort of case, like not the routine clinic में देखते हैं। ठीक है, evaluation cover all the points जो कि whenever you see a patient, evaluate a patient on the basis of these tests and all the standard thing, but there should be the वो आपको आता ही है तो आप अपना standardized questionnaire के साथ उसको present कर सकते हैं। ठीक है, but case should be an interesting one that
Madam, I would
required
like to do
urine.
general club.
या आपका तो जनरल क्लब भी है ना, बिकॉज आपने किया नहीं
जी
अभी
मैम।
तक। ठीक
जी
है
मैम, जी।
जी
I will do the
ठीक
presentation, the case presentation.
है। और सदफ, यू कैन ऑलवेज ब्रिंग योर केस टू, वी कैन अकोमोडेट दैट। ठीक है, ताकि हम एक का इवैल्यूएशन का पार्ट कर लेंगे और दूसरे का मैनेजमेंट हम डिटेल में डिस्कस कर लेंगे दोनों की। तो अगर आपके पास हो तो यू आर मोर देन वेलकम। ओके
Okay, I look for one if I find it.
ऑलराइट, थैंक यू वेरी मच एवरीवन।
Thank you very much,
Another
ma'am.
interesting session of ours. Okay,
Okay.
laugh.
Okay, thank you very much. I think we're done for the day.
Yeah.
Thank you.
Thank you so much. And I'll share the link by Friday, inshallah.
Thank you, Dr. Nazli.
Love
Fellows, are you learning from this activity?
Yes,
आप
yes,
लोगों
it's
को
very
बहुत
beneficial.
तो नहीं लगता हर हफ्ते प्रेजेंटेशन बनाने
नहीं, but
हो
good for
जाता
our
है।
हो जाता है?
मेरा
चले
ख्याल है
अब
कि इसी तरह ये बच्चे पढ़ते रहते हैं और इट गिव्स देम एन एक्सपोजर, और मुझे तो ये लगता है कि ये हमारे लिए भी बड़ी अच्छी लर्निंग एक्टिविटी है। सो फेलोज शुड ऑल द मोर बी हैप्पी एंड यू नो दैट वी आर enthusiastically looking forward to it. This is one activity I really look forward to, this activity throughout the week, and I'm really very keen to be present in this. So fellows should actually avail this opportunity because it gives them a wider exposure to different perspectives, to practices across different institutions. It boosts your confidence and also helps you identify where your weaknesses are and where you can improve. And I think it will also help us in bringing a uniformity in our practices as well.
या और लेट मी टेल यू कि आज आप लोगों ने जर्नल क्लब को जो है ना इतना थॉरली नहीं पढ़ा हुआ था, बिकॉज ईच एंड एवरी line and each and every study which was mentioned the journal club should आप उसको थोड़ा सा लुकअप कर लिया करें, एक ग्लांस दे दिया करें लाइक एब्स्ट्रैक्ट निकाल कर। सो आपको हर चीज उसका पता होगी तो यू विल गेट मोर एंड मोर इंटरेस्ट। एंड बिलीव मी, when last year we had our two very good fellows who had approximately, they just submitted 8 publications of theirs. So उनका ये था कि they learned a lot from this journal club activity because it increases your research acumen too. So it's going to help you a lot, लेकिन फायदा जब ये होगा जब आप इसको thoroughly पढ़ के आएंगे। Like any trial, सब कुछ is going to enhance your knowledge passively। आपको अंदाजा होगा कि कितनी knowledge आपकी increase हो गई है for the period of 3 months or 6 months में। ठीक है, चलें, thank you very much।
Thank you.
Allah Hafiz।
Allah Hafiz.